Get the big from down here.
All right, good morning. It's Thursday, March 19th. This is Senate Health and Welfare, and we always begin the day with something good. And today that good is having some physical therapists join us. I'm glad that you're here. So we're going to introduce ourselves to you, and then you can introduce yourselves for us, and we'll listen to your presentation. It's great. Go ahead, John.
John Morley from Morley's district. Nice to meet you.
John Benson from the Orange District.
Ginny Lyons, Chittenden Southeast.
Martine Laurent Buick, Chittenden Central, in Cummings, Washington.
So this is it for health and welfare, but we have, I think we've been pretty supportive of physical therapists, and we would like to continue doing that, but in order to do that, we need to hear from Ginny. Thank you for being here.
Yeah, thank you, Chair Lyons, for having us. Thank you, committee, for listening to us. I'm Heidi. I'm the physical therapist from Middlebury, and I am the president of the American Physical Therapy Vermont chapter. And I cover Addison and Rutland County.
I'm Elizabeth Sargent. I am also on the executive board of the Vermont chapter. I've been a physical therapist for over 30 years, most of those in Vermont. And I am in Franklin County.
My name is Estelle LeClaire. I'm a private practice owner in Essex, Vermont, and Georgia. We also do a home division on physical therapy. And I recently took the APTA role of the policy and payment chair.
So thank you for having us come and speak. As the chapter of physical therapists in the state, we represent over 400 PTs, PT assistants, and students. We cover a lot of different sectors that sometimes I think people don't realize the whole lifespan that physical therapists can really help with. We're here to help, educate everybody on the role of PT and how we can help increase quality of life and save our society money. I run a private practice down in Middlebury, and I do home visits for babies. I'm a birth to 5 specialist. For the past 12 years, I've only taken Vermont Medicaid because I think that's where the most need is for early intervention, which is the birth to 3 program in the state. I do provide services in the home, and I cover all of that, and in some of Rutland County too. So to provide services in the home and in the kids' natural environment is pretty costly. It has been really hard for me to keep my business open. And unfortunately, right now, with the changes that are coming from Medicaid because of the federal changes of the evaluation code that we've been using for the last 15 years, is going to put such a significant cut in my business. I'm going to have to change my priorities, and I'm no longer going to be able to take just Medicaid. I'm no longer going to be able to see just babies, and I won't be able to do it in their homes anymore because I'm going to have to figure out how to keep my business open, which might include going to more cash pay. Which I know is not great for equality and access, but I have to make sure I feed my kids. I think in early intervention and even pediatrics and neurology, if people have a neurological condition, the amount of services that it really takes for them to meet, their proper outcomes is really tricky. And I think if we don't meet the kids' needs, it's going to increase our school budgets. A lot of the school budgets are really high right now. A lot of it is because of healthcare and because of the special education services that are needed. If these babies don't get their therapies, PT, OT, and speech when they're little, those services and the needs are going to go up tremendously. We have a lot of young families that are moving out of the state because they can't find services for their kids. And then a lot of people like me aren't staying in the state because we can't run our practice. So PT is just really, really important.
You work directly with special educators for kids with special needs, any patterning or.
Yeah, so usually that's not until they're 3 in the educational system. So I work with the early intervention program usually, but I'm also on the medical side. So if a lot of people, maybe if an adult had a stroke, they would know that they would need a lot of rehabilitation, but a lot of people don't realize that babies have strokes. And it's not just high needs parents or parents that have used drugs. It's well-educated working families who have issues. And unfortunately, if they don't get the therapy that they need when they're younger, they may not be able to walk. We might have more kids end up in wheelchairs than we do now. And the families and kids can't get the equipment unless they have a PT involved. We're vital for getting them wheelchairs and walkers. But it's still really tricky for administrative burden, how much work and how little I get paid for it. So it's really hard for me to keep it open. So I'm just here to help educate what we can do to help.
Have anything else? Because we're gonna have lots of questions, but we
Yeah.
want you to get everything.
Yeah, so I'll just be brief. I'm here also to help improve the understanding of Dr. Physical Therapy education. I'm a DPT educator. And have been for the last 10 years. I'm for faculty at the University of Vermont, and now I'm also faculty at a hybrid program in Eastern Kentucky, Appalachia. So I'm quite familiar with trying to meet needs of rural citizens. And the DPT education, if you look at the curriculum, it is not the layperson wouldn't be able to differentiate it from an ND program or a DNP program. They are very similar. And the reason I wanted to point that out is because I think if PT can be considered part of that primary care team, it reduces barriers to Vermonters, improves access, reduces cost. So when I was working in the primary care office with physicians at Memorial Health Partners, that improved access, improved outcomes, improved patient satisfaction. And the patients were able to get treated faster, and the physicians and nurse practitioners were so grateful that I could help unburden them because they are, burdened. So
So the question that I have about that, I'm glad you brought this up because obviously we're pushing forward a bill, S-197 on primary care based on the blueprint model.
right.
So do you work within a community health team? Do you participate in that blueprint process? So in effect, you are primary care folks. I do see you as primary care.
So it depends on the team. I was
Yeah.
part of a federally qualified health center.
Yeah,
There are some billing challenges that are part of the Medicare handbook, and that's got to be handled at the federal level. So, however, as part of the primary care team, 35% of visits to primary care are musculoskeletal problems. So the physicians and the nurse practitioners are not trained to handle those cases, and they need to offload those to us. So some of the challenges are payment, some are legislative, but none are scope of practice challenges.
yeah, some of them just administrative stuff.
So I'm independent, so no, not for me.
But then you're talking about code changes through the federal government that sound that whole bill that's coming up for Medicaid is gonna hit everyone.
Yeah.
Not.
Yeah, and so what we're hoping is maybe the state can come up with ways to pay us for the other things that we're doing, some of the administrative pieces or the collaboration pieces. I don't get paid for team meetings, although for a high needs kid, they're asking to join monthly for an hour meeting is a lot of non-billable time for me. The travel is tricky too, especially in the rural state. So
This is an ongoing issue. Are you, you're all in an area that makes you eligible for the Rural Health Transformation Grant. And I don't know if your organization is looking at what RHT is doing, and it does include primary care and it does include transportation. Have you looked at any of the opportunity there? And I'm thinking it's difficult for you in your practices to do this. You can't do it, but the organization itself might be able to put something.
I haven't, only because a lot of the things that I've seen are going towards nonprofit agencies. So I'm not familiar how that would help my piece.
Oh, we
yet,
gotta
but-
get you looped in. Yeah.
Yeah,
Yeah,
so
yeah.
and that might be something for the rural things. We know that there's lots of pieces and there's lots of other bills that we know like PT can be part of. I mean, we can really help the workforce, if people are out on workman's comp, and I know Estelle's going to speak to that a little bit. But I think there's a lot of areas, that we can really help with.
I think one of the things that we should look into is how the code is written in terms of who is considered a provider. Sometimes those are defined as NV, NPPA, and a PT is a designated provider, it would remove enormous number of barriers in terms of being eligible for grants like the ones you're describing. And so, might be something
Yeah.
along those lines we should look into.
So that, all of everything you just said about,
Yeah.
well, designated provider, that's something we can dive into.
Yeah.
But some of the code changes, and which codes need to be supported differently,
Right.
and what administration needs to be supported different, need definitely specific recommendations.
Right.
I do have to say Medicaid has been really, really good. And I want to thank them and you guys also for supporting that. So they have decreased our administrative burden a ton.
Been
So
working on that.
yeah, and that is definitely, so thank you. So now we just have to figure out how to not let the federal changes kind of squash us.
I know, just when we get started on doing good things.
Estelle, did you want to talk about?
I love the idea that you start the day with something good. I wish I could follow that in private practice. I've seen the biggest challenges, there's tenfold, but the biggest challenges for us in private practice is having practitioners. Right now in Chittenden County, there's a huge wait, 4 to 8 weeks at any given time for people to get into physical therapy. That's a problem in our state. The challenge for me as a business to provide insurance for my employees with the subsidies going away on the Healthcare Connect. Getting insurance for a small business is costing me 3.5% more of my revenue than it did a year ago. So in January 1, my costs have gone up 3.5% of my revenue. That is not sustainable in Vermont. I'm fortunate. Some practices that are small are calling me to say, can you buy my practice? I'm ready to fold. I'm ready to go back to work at UVM. The hospital, I should just close my practice. It would be easier for them. So that is not, I don't believe that is what we want to see in Vermont. I think small practices and small businesses in Vermont are an important part of our state's picture. And we know that private practices save money for the healthcare system. So between keeping staff here, affordability in Vermont in general is enormous challenge. Just yesterday, I received a resignation from one of my clinicians. Third one, moving out of Vermont. That is not what we want to hear this morning or in general as a business. So with that said, what do we do? Whether it's pelvic floor PT, keeping people out of nursing home care. That's the number one reason women go into nursing homes. Incontinence issues. That becomes a problem in healthcare. UTIs, that lands you in the ER, which is far more costly to the system. ER visits, physical therapists, with Elizabeth speaking to the doctorate level of education, we can treat acute vertigo. If you've never had vertigo, good for you. That's a happy moment.
Yeah, no, it's not a good thing.
If you've had it, you know that you think you might be having a stroke and you need to go to the ER. You don't need to go to the ER. You can go to first line care at physical therapy first. That saves money to the system. Low back pain, same thing. Those are acute areas where we do function as primary care providers. Thankfully, a lot of people know each other and they say, oh, if you've got vertigo, we saw a therapist over at that clinic. And they know that they can come to us first. So whether it's pelvic floor, whether it's workers' comp, as Heidi mentioned, getting people back into the workforce, those are the places where we hold a huge part of the healthcare system and just community members in our state.
And I'm glad that we're doing a lot to try to keep, students that might be graduating. We're trying to work more on keeping them in our state because a lot of students leave. We have a very small percentage. We only have one DPT program, the doctorate of physical therapy program. But I think it's good to, be working on student loans and stuff and keeping them in the state. But we also have to figure out how we can support the providers that are already here.
So I'm looking at our time, but you've got more information. This is great. I really appreciate what you brought to us.
We want to help you. We want to
But we need all the help we can get.
We need to work together. We
So,
all need to
but
work together.
do you have your written testimony, all the things that you've talked about? We have And
Yeah, we had sent the other things and then
Yeah,
this is just
this is
like
great.
another summary for
Good.
it. Um,
I don't know that mine, made it.
No, we didn't
Mine
either.
yesterday.
if you have something further, just send it in.
Yeah.
And we'll look at it because honestly, every time we hear something like this, I think, oh, we should have put that in that bill. And so going forward, as we look at what's coming to us from the House, we may be able to put some provisions in or in the budget. This is helpful.
This is one code. I heard, I heard it. This is one code, but for her business, it is capsizing. It's the boat goes over.
Yeah.
She can't stay in business. This one
Yeah.
code with Medicaid. So just one code, you know, if you look at it collectively, you think, oh, not a big deal.
We all need to go to the federal government and get them.
I'm going to Oregon.
Yeah.
Right.
Yeah, let us know if you guys want more information. We've got lots.
I do, this
Yeah.
is helpful.
Thank you.
The discrete, recommendations, really great.
I will
And-
send you additional information.
Please do. Yeah.
And I like numbers, the numbers.
Send the numbers.
Try not to go on feelings, just try to go
Yeah.
on data.
That's right.
Yeah.
Data is what matters.
Right, thank you.
Thank you.
Well, thank you. Thank you for your work.
Thank
And the rural health transformation grant,
Yeah, we will look at that.
you need to get in touch.
Yeah.
Maybe Calista, I'll give Calista some information to connect with you so that you can get on that as an organization, because there's really a place for you.
Great.
Great.
Thank you for that lead.
Bye-bye.
All right. Senator Bongartz, thank you for being here. We got a 5-page amendment.
Oh, my goodness. Well, it's not.
Thank you.
So is Katie coming in on this one or no? No. Well, so here's what we're gonna do with this. First, we'll have you explain what you have here for the amendment, and that's we have time for. Then at some point, our committee will dive in for a discussion, and consider how we might support or not support on the floor or neutrality, but so I know that you're very interested in this. So why don't you go right ahead?
So what the bill does
First
is,
for the record.
oh, yes, sorry. As I always say to everybody, yes. Senator Seth Longworth from the Bennington Senate District. And what this bill does is allows somebody to open a home child care center with a level 1 certification or license, and then gives them a total of 6 years through extensions to gain their level 2. So my fear is that we go straight to requiring the level 2 before somebody can open a home center, which can be no home centers. Because it's too big a lift out of the box. But if we can get possible for people to get started and then give them with a minimum with a level 1 license, and then give them for 6 years to get the rest done, that we'll get to the place we're trying to get at. We'll have more home child care centers in rural Vermont where they're, I believe, desperately needed. And I also just added a couple of things to the study on page 4 of this. It looks like there's a lot new, but there isn't. And it's to number 5 on line 12, page 4, and number 6,
I see it.
and changes in the number of registered licensed family home since the enactment of, and then recommendations to encourage the opening of additional family care homes. And that's it. So that's what the bill does. Those two things makes it possible to open while you obtain your next level of certification or licensure, and adds language about the study.
Okay, Senator Druid, everybody.
Thank you, Senator Bongartz. Is this for is in perpetuity, they'll be able to open a home center with a level 1?
Yeah.
So right now, the period of time is what, 9 years for the beginning of this to take place. And you're suggesting that in order to, after that 2031, I guess it was, after the time period that we have in the bill,
2029.
2029, you're right.
Yeah.
after that, there would be a 2-year period. You could open your home. You could then go to get your credentialing to move forward. And if someone else came in 2034 and they want to do similarly, they could open a home and then they'd have a 2-year period within which to meet the conditions for continuing. Okay,
6 years special.
yeah, it's good. So,
This is a comment rather than a question, but as I look at the requirements for ECE one, it's strictly field experience and no actual learning.
right,
And that concerns me, just because we talked a lot yesterday about that
Professional.
neurodevelopment and
Yeah.
professionalizing, but also just understanding trauma informed practices and which you don't necessarily get in just field work. So I guess I'm a little concerned about that it's just going in perpetuity. So I'll leave that
so
there.
the period of time, I understand that at this point, there might, and going along, there might be people who get the great idea that we're, I've got experience here taking care of children and would like to open a home center. I can understand that happening. I think the concern you're raising, and correct me if I'm wrong, is that this would just go on forever rather than have a limitation of 2040. So it's day out, that's all. Okay, but so we'll talk about this. I think first we want to understand. So questions about understanding. Correct me if I'm wrong, but you're saying someone with a level 1, which is experiential. I have 3 kids. I would like to open a home center and take care of a couple more kids. I have 2 years
Yes, with extensions.
with extent, but
Yeah.
I have a time frame in which I need to get some educational credits.
Yes,
It's a number of years. I think we need to remember we're sitting in Chittenden County, right here in the megalopolis of the state capital. I forget what bill we were looking at. May have been licensing adequacy. There was childcare on the west coast and there was childcare on the east coast of the state. And there was a huge swath in the middle where you don't have enough kids to open a center. I mean, the population is such that probably for the foreseeable future, the only practical way is to have a home center. And people that live up in Island Pond are not traveling out to get a degree. I understand the need to professionalize this, but honest to God, I'm a history major and I raised 4 successful kids. And they all read and they all are law abiding. And I didn't know anything about brain development. Women have been raising kids for years, and I am proud to see women's work being recognized for the importance that it is. But I want to make sure that in trying to do a good thing, we don't undo. Okay, Senator, I'm going to ask for questions of Senator Bongartz regarding the proposal. Okay.
So, because sorry, I haven't had time to read this. I'm just seeing it for the first time.
Yeah, that's
So
all.
I wanna
We don't have Katie yet.
Yeah, and I just want to make sure that I understand. So you could open a home-based facility with just an ECE one, but you do eventually have to move to an ECE two. Okay, thank you. That's helpful. I wasn't getting that.
No, they don't, they can't just keep going at the level 1. They have to go ahead
Got it.
and
Okay,
achieve.
thank you. I didn't get that at first. Now I get it. That's helpful. And then they can stay at ECE two. They don't have to continue to 3. Okay. And they have 2 years to move from.
you can get extended. You can.
Okay.
Yeah, paid.
Okay.
Yeah. So, yeah, understood. So I appreciate everything I really, and I get the notion of the little
Yeah.
guidance that comes with having, and it's just that in some areas of the state choice, if you'll have some areas of the state can have this, and then my fear would be some areas of the state with nothing. And getting to here in those areas where that's what's required, to provide, to have families go to work and have a decent place for kids to get on schools, what I'm trying to get at.
Understood.
So recognize the realities on the ground.
Yeah.
Yeah.
So, okay, rural.
Yeah.
Thank you.
I don't think we're gonna see 100 of these things happening overnight. That's some, but as you said, someone might decide about this experience, I want to expand. I've been taking care of kids from 2 families, 6 kids for 6 years, and now I want to open up and do something different. So
It's a hard job.
they still have to register with the OPR.
Yeah.
And apply for a license, a level 1 license, and they still have to then commit to education.
Getting.
Okay.
Yes.
I think we finally understand it. Good.
Next.
Oh, just in time.
Next.
We're gonna move, we're gonna
You're
replace you
Thank you.
with
With,
Katie, and that's great. Thank you for bringing this in. Yeah, it's very, thank you.
So actually somehow, if somebody could let me know, because I have to get it up to,
Will do. Yeah.
somebody.
Yes.
Send the courier over.
Yeah.
Thanks. Well, I'll be in, but yeah, just send this.
Oh, all right. Yeah, go ahead now.
Emily, can I ask you a question, please?
Yes.
The 60 college credits that the ECD2 needs, I hear Senator Cummings' reluctance because of geography and like schools and all of that, but there's some, I would assume there's some great online college credits that you can get from, even if you're in, wherever, any part of the state, Vermont or, where, I don't know, all the small towns, I could name them all, but do you know what I'm saying? Like, it is available.
Yes, yeah, Emily Tenenbaum on record, Westbrook Action Network. Yes, I'm certainly not going to speak about where and how accessible they are, but certainly there's a ton of online options. I think what you want to look at when you're looking at EC1 and putting someone in an on-ramp, there could be a sole provider providing for 6 kids at that point. So I worry about the drop off and the ability to actually get to that EC2 once they've actually opened that center. That's one thing to think about. Whereas that
I don't want to get into full
Yeah.
testimony on this because we've had testimony, but the question about education was fine.
Yeah, it's all
Yep.
over diversity. Yep, there's
perfect.
ways to access in all areas of the state to get. this.
Understood.
Great, thank you. Yep,
Yeah.
sorry, thank you. It's okay.
Okay, so Katie, we're looking at Senator Braungardt's proposed amendment on 206 right now, then we'll move to the 193.
Okay,
Uh,
good morning. Let's see, I didn't realize this is where we were starting, so let me just pull the document out.
Well, things happen rapidly.
Yes, I'm
think
very
this
well
was-
aware.
I think this was when I was sitting here last night around 6 o'clock.
Oh my, it has been a week.
We're still in committee. I know, you guys are still working.
Well, this is good timing. Our document management system isn't letting me open the document. And you don't have a draft of it listed?
206,
The amendment?
Yeah.
we have,
You do have a
we
copy.
have copies.
Oh,
Do you
okay.
need-
I have a copy,
Okay.
but I just can't.
We can go through it physically, with our neighbor.
Okay.
Yeah.
Okay, great. Okay, McLean Office of Legislative Counsel. This is instances of amendment, as you can see. It adds a new type of variance specific to family, family, childcare providers. And we have some varied effective dates, which is why the section appears a couple times. Unlike the other variances that are time limited, this one is permanent. So let's just walk through it. So in section, we're striking out the repeal of the variances because that section is being retained with one variance. And instead, we're putting in a new section 4 and 4A,
both of those sections amend the same underlying section of law, which is 206255. When the bill is enacted, it will have a variance in subsection A and subsection B of this section. And then, at a later date, check my effective dates, January 1, 2029, this subsection C is added, and that is after the date by which somebody has to have a family child care provider license to get the family child care provider license type. And after that January 1, 2029, somebody operating a family child care home would come in as an ECE 1, 2, or 3. Do you recall that conversation, how that license type goes away? So on that date is when this new variance is established. This language says that the board is to issue an ECE 2 license to a provider operating a family child care home who does not meet the educational experiential licensure requirements of the ECE, I should say 1.
I wondered about that.
Oh, no, who does not meet the requirements of an ECE 2. That's correct, sorry, but does meet the requirements of ECE 1. So basically what this is saying is a person who's operating a family child care home will be treated as an ECE 2, even if they only have the educational experiential requirements of an ECE 1. And then there's language to say that a transitional license under the subsection is valid for a 2-year period and renewable for 2 additional 2-year periods. So that's up to 6 years for that variation, or where somebody who only has the ECE 1 credentials would be treated as an ECE 2 for the purpose of operating a family child care home.
What are the educational requirements, going back to Senator Gulick's question regarding educational requirements that would be have to go through for that 6-year period? Because it becomes a 6-year period.
Yeah. So ECE 1, the person has, this is the wrong section.
So
There we go. So for an ECE 1, the person has received a certificate from an approved credential program in early childhood education requiring a minimum of 120 hours of training and instruction. 2, ECE 2, this person has received an associate's degree in either early childhood education or related field requiring a minimum of 60 college credits, or any unrelated field and a minimum of 21 approved college credits in the core childhood education competency areas. So those are the differences between the 2 license types.
So-
And this would, I'm
go
sorry,
ahead, sorry.
this would give a permanent variance that somebody who wants to come into the field as a family child care home provider would have 6 years to attain the educational difference between ECE 1 and 2.
6 years.
Well, the variance is 2 years and it says up to 2 additional
Right.
2-year variance.
So if, I'm thinking if it were 1 additional variance, that might be more appropriate.
So 4 years.
Yeah. Rather than 6 is a long.
Yeah, 6 is.
And because look they're running a center without the credentials that everyone else is needing. So can be a little bit understanding, but 6 years is a long time.
It is, and it isn't. You're running business probably from 7 in the morning until 5, 6 at night. You live up in the middle of nowhere. You may or may not have access to the internet. And to get college credits, you're going to have to, and you have children of your own and perhaps no partner. And you are going to have to get in your car and go somewhere to get college credits.
I would agree. I understand that hypothetical situation, and I understand that that is extremely possible. However, we're passing a bill right now in 2026. Hopefully. And if someone wants to open a home center, they're gonna know what the requirements are. And that there's also experiential learning validation, there's online learning. I know let me tell you, I know that the expansion of Wi-Fi is going, it's gonna be there, it's gonna be an island pond. I know, we've heard that in appropriations, it's gonna happen sooner, everything. And but if you go out to 2034, by that time, things ought to be pretty well understood. 6 years seems a long time to move from the certificate to the associate's degree, that's all I'm saying. Go ahead.
The beauty of the original bill was that folks would have already done that work when they opened up their centers. So if there wouldn't have been this competing, I'm trying to work while I'm doing my coursework, the coursework would have been done. So that's what I really like about that original one. And I don't know, I think, you know, the ECE1, I can imagine a world, a landscape where you have a lot of sort of apprentices who are apprenticing with the folks running their home child care centers who, and then they decide they love it, they want to keep going, and they can be working on that degree while they're apprenticing as ECE1, but that was all in the original bill. And
Where does their money come from? The reality is, and they're generally single women, need to feed themselves. Generally, apprentices don't get paid or don't get paid a living wage. We're having trouble. Part of this bill is to pay the providers a living wage. Maybe it's that I've spent a fair amount of my life working with very low income and understand the difficulties that they face, that people with more means, they don't have a car that's reliable.
So I'm gonna just flag that 2 year, and I'm gonna suggest we reduce it to 1. And I think we should continue going through the proposals.
Okay. So then we have a new section 4A. Again, we're amending the same section we just looked at. In your bill, the first two variances, A and B, are set to sunset on July 1, 2036. And this achieves the same thing, but it retains the new variance that's being created in this
The two.
draft. Yeah. So whereas we could have done it just in one sentence in your bill because the whole section was going away, now we have to show this straight through because we're retaining some of the language. So that's what the difference is.
So the variance for the home center with the 2+2 continues.
It does indefinitely. Page 3, the bottom of page 3 is the second instance of amendment. This is your reporting requirement. New language here, I'll point out where that is. First, initially this report was being done by OPR solely. Now it says OPR in consultation with the Department for Children and Families Child Development Division. The reason for that is that there are new reporting requirements in subdivision 5 and 6. And I think some of that data would require CDD to be able to answer that question. So that's why CDD is added. So those new reporting requirements include any changes in the number of registered and licensed family childcare homes since the enactment of this licensure act. And 6, recommendations concur to the opening of additional family childcare homes to be part of that report. That report is a 2031 report. Okay. And then we have effective dates changing to reflect the fact that we have new sections and new tiering. And also now that we know that the Appropriations Committee report was accepted, an effective date for that section that was added about the contingency of funding. So sort of irrelevant to the proposal, but necessary to the function of the bill. Page 5, line 2, 6A, contingency of funding.
takes effect July 1, 26.
That's approved.
Yeah.
Okay, there. Okay, so. Now. Let's take a couple minutes to discuss this. And then we'll dive into 193 with Katie. First, here's what I'd like to do. I've got a question.
Well, it is a question.
Yeah, go
and
ahead.
I'm not for anyone necessarily around this table, but
Yeah, go ahead.
to Senator Cummings' point, because I have a lot of, I mean, obviously, Burlington is actually a high poverty area. People don't realize that, but it is. It's
Hugely high priority.
Yeah, Winooski is as well. So we, I understand the restraints and issues around poverty. I'm wondering if we could find out, or if we can get a sense of what kind of scholarships and grants were included in Act 67. Because Act 67 had a lot of, developmental work. Yeah, exactly. Is that something? I don't know. Again.
Well, I think there will be some changes to it. I mean, so part of what we'll see is during the budget process or some of the workforce bills. And I can't answer that question. I don't know where they are right now. Go ahead.
I guess I don't have a problem with the 6 years, because I can see somebody starting the business, not knowing if this is what they really want to do. And that first year basically is completely lost. They don't really start on entering into the higher degree of education for a while, but they know this is what they really want to do and want to basically retain the service. So
let me respond to that. I mean, if they're going to apply for the license to be a home center, they're going to have to meet requirements through OPR. And they're going to have there'll probably be some rulemaking around this that says they'll have to have a timeline for achieving goals. And 6 years is a long time.
it is, but it goes fast.
Probably 4 cohorts of kids, 3 or 4 cohorts of kids.
Yeah, it's a bunch of kids. That, for me, that's a sticking point in this one for me. I don't mind having a variance. If we can really encourage more workforce and more opportunity in parts of the state that don't have it. I'm okay with that. I am very concerned about the time that is embedded in here.
Speaking of OPR, have they weighed in on this amendment at all? Can we hear from them?
No,
No? Okay.
it's our decision. Check. So, I mean, we don't even vote. We don't even have to vote on this. You understand that?
Yeah.
We can do a straw poll. We can make a recommendation about any of the language, and that's what I was raising. I don't know whether the proposer, Senator Brancard, would welcome that or not, but that would be something that we could consider.
Okay. OPR will be in a position to be supporting these folks.
Yeah, they'll have to work with it. I mean, remember, the next step is the House. We'll also have other opportunity there to look at it. If this passes, I mean, honestly, it may not even pass the full Senate. So remember, it's an amendment being proposed by one person to move it along. Senator Bond, I have a question for you.
Oh, you do. I see people work on.
So, you know what that indicates that you didn't really want to leave.
Yes.
Good. We're glad that you're back. But question. So within here, you have a renewal of the transitional license there would be a total of 6 years. So they're in 2 years, renewal 2 years, renewal. And my concern is that 6 years is a long time. What would happen if it were renewal once,
So 4 years.
4 years?
On one level, even me making that decision, making it has a little bit of arbitrary.
Yeah.
The number is always arbitrary, to some degree. So you might have a better sense of that than I do.
Okay.
I just wanted to make sure that it wasn't too much, too fast, and that people have to be able to do it.
Yeah. And what we're talking about in here are cohorts of kids who are going through, a facility that doesn't yet have a fully licensed provider. So that's what we're doing about.
But we know where you end up.
Oh, we will.
And gotta get it to John.
We'll let you know.
Yeah.
But thank you.
Okay, yeah, I don't have would I prefer 6? Yeah, I'd be fine. I prefer 6, yes.
Okay,
Just make sure they have enough time.
thank you.
Okay, thank you.
Thank you. Okay.
I do like about this amendment. I'll try to be positive. It's, what's nice is if you're working toward an associate's degree and you're only lacking your last 3 credits, you can open up that center and you can get those 3 credits over 4 years or whatever we decide, and then it's done. So I guess I will speak to the positivity of the incremental,
I do like that.
aspect.
So if we recommended to Senator Bongarth that we took out that last 2 years, just said 4 years, then I would that be okay? You guys? I mean, he seems okay with it, and I think it makes sense. And then based on what Senator Gulick has just added, which is lightning.
I'm just thinking of my district, my folks at home and the situations there. And and the education requirements and their the stress that they're under, and providing them more opportunity isn't necessarily a bad thing. So I don't see the harm. I haven't seen the harm there, or no one's convinced me that there's harm keeping it at 6. I just don't see that. Me personally. So I have no problem supporting the senator's amendment, unless I hear something different.
Okay, can let the straw poll. How many of you would like to ask this backwards, gonna ask it in my favor. How many of you would support it as it is rather than the 4 years? Okay, how many of you, if it were 4 years, would support 4 years?
Can I speak to it real quick? Which is just that this is all pretty arbitrary, and the work that was done in the Sunrise Review was based on a lot of.
Whole lot of research.
Yeah, so I'm kind of loath to support it, but I will. I'll support the 4 years. That's what we need to do to.
So now I'll go back and ask the question again. Would you support the change? And Senator Bongarth was open to that. Would you support the change to make it a 4-year period and not 6 years is a long time to accomplish this. And I know you think it's not, but it's huge. It's huge, and it will have a devastating effect on kids.
Even if that's what it is, I'm concerned that we do have childcare deserts in the state. We don't have enough kids to open a center. It's just not financially viable if there's 4 kids in a 10-mile radius. And the reality of trying to run a business, we heard the very well-educated physical therapist talking about how difficult it is to keep a business open. Plus, you may very well have your own family and your own kids. And so to keep people, it's good that we want to have great childcare. It's like insurance, but if we make it too difficult, we won't have any insurance.
Okay, so the proposal that came to us from OPR has been done with extensive research. What we're doing is we're opening it up to a variance that was not in the original proposal. And the variance could allow a 4-year period. This one says 6, 4 years to finish your associate's degree. Long time. Anyway, so I want to finish this right now. So how many of, I'd like to start a poll. So you see, I'm going to push my position. How many of you would support the 4-year period? Because this will be important on the Senate floor. You have to understand that. How many of you would support the 4-year period? Okay. How many of you will support the amendment as brought to us by Senator Muffins? Okay, that's it. We're done. And I'll let him know. But I'm going to say I think it's a huge amount of time. And so that's it. Thank you. Thank you all. And Katie. 193, we have it. We looked at it yesterday, but I didn't think we had the 24/7 in there.
Okay, let's make sure we're looking at the right version.
And then we're gonna go to 190 and we should get Jen down.
Okay, so this is S-193. This is draft 4.1. Oh, I see what's happening. So that's why I could not open documents. Word is frozen on my computer, which is
Well, that doesn't help.
phenomenal. So let me grab my hard copy, and it sounds like you all have copies, so you're in better shape.
You know
than I
what?
am.
I'm gonna make an exception. Would you mind can you put that up now?
Because we have
Almost.
3.
Is that-
193. I don't usually do this, but I think it's important.
Right.
You don't have
Number 3 point.
We have 4.1. Oh, no.
No, I don't.
4.1 is online. 4.1.
You have
3.1 is what we have.
Okay. I probably have it in an email, which means I could forward it to Calista. So,
Oh, so I was looking at 3.1 last night and I thought we had gone backwards with new language. So now
Yeah, right.
we're good. You were looking at it in institutions, so you
Most we had was 3.1.
got it.
So that was the problem. Katie was not available.
That's
okay, I have it in an email. So I'm just gonna forward this email to Calista.
Thank you.
And then it has the PDF in it. Okay, I might just restart my computer because that's where we are right now. Okay.
Just show up.
Did you receive it, Calista?
I'm sure it's happened. It's okay to have a little pause, actually.
Okay.
I kind of like it. Just take a breath and, no, this is good.
Or maybe I could share from this PDF. See what happens if I try that.
I mean, honestly, we should all do it in these moments of
Stretch.
well, just stand up. They say just standing is good for your health. Standing and then sitting back down again. Thanks, John.
I do feel better.
Right? Sitting is, I used to say to my students, like, sitting is the new smoke. It's just
Sitting
really
is
bad
horrible.
for you. It's so bad.
so awful.
And we do a lot of it. We do a lot of it.
Okay, so I have a PDF. So I think we're good, Calista. Apologies.
Probably look that.
So, draft 4.1 of S-193, we have yellow highlighting that's older new language. The highlighting in green, I'm not sure if you looked at a version with green highlighting yesterday, but green is what I think I haven't walked through this committee.
I haven't walked you through the green language yet. So that's where we are. I learned while I was testifying in Senate institutions that this committee does not have custody of S-193. So a previous version had this as a committee report, but it is not a committee report. So this is now being presented as in the individual senators' names. So I put it in Senator Lyons' names with the ability to add any other names. So that is that change. Trying to remember what our changes were here. So we have our first instance of amendment. This is in the section about the forensic facility. It has definitions.
We went through draft 3.1
Mhm.
yesterday, but so you can walk us through pretty,
High level.
go right ahead.
I want to bring you to all the green language, but just to set up where this is in the section of S-193 where it has the definitions of forensic facility, has definitions of a qualifying condition, and then we have this language that's not highlighted. That means it's language that came from Senate Judiciary. Yellow language is language that you added, and this is requirements of the forensic facility. So being added here is that the forensic facility shall ensure that a registered nurse licensed pursuant to Chapter 28 or physician licensed pursuant to Chapters 23 and 33 of Title 26 provides care to transfer persons 24 hours a day, 7 days a week. So that is a requirement there, somebody with clinical expertise always available. Not just available, but present. And then in 7, there's a request from DMH to have this language an initial person-specific treatment plan. So that is that addition. That brings us to the second instance of amendment. And this is adding an annual report at a later date. DMH requested that the Department of Health be one of the entities that DOC is consulting with in preparing this report. So Health Department is added. And then we have the reporting requirements, and like the language up above during the previous calendar year, that was added in subdivision 2. That brings us to the third instance of amendment, rulemaking. Similarly to the previous section where DOC consults with various departments, Health Department has been added to this list. And then in terms of creating the rules or the contents of the rules, we now have language that the rules will address any other provisions necessary to ensure safe, effective, and clinically appropriate implementation of the forensic facility sections of this act, including potentially requiring the provision of forensic facility services in a unit that is separate from other correctional populations. Section 7 is an interim report. Again, you're adding Department of Health to the list of departments to consult with. Interim report shall address. That brings us down to subdivision 2. Forensic facility planning, including the specific proposed location of the forensic facility, space considerations and design elements necessary to support the provision of therapeutic services and security at the proposed location, and the timeline for any necessary fit up of the forensic facility. And then we have our effective dates. So this section meaning effective dates. Section 2, which doesn't pertain to the forensic facility. The rulemaking and the interim report all take effect on July 1 of 26. 4A that you just looked at with the secondary report coming in at a later date is July 1, 28. And then the sections about the forensic facility themselves and operationalizing the forensic facility processes is January 1, 2028.
Cool. Okay. Questions? Go ahead.
Thank you, Chair. Madam Chair, the part about the registered nurse, does that nurse have to be physically on the campus or in the facility, or can they be online or?
Let's see, Chair, they provide care. I guess we could tighten that up if you, the intention, I think, behind it was to have somebody physically present. provides care, I guess there would be an argument that I'm providing care via,
Or could say available to provide care.
yes, I think that is different than what the original intent
Yeah.
behind it was. Maybe something like, or a physician shall be physically present to provide care 24 hours a day.
Senator Benson, and then I'm gonna turn to Department of,
I sort of had a question along that same lines, and so this says that these folk have to be there 24 hours a day, 7 days a week. And I was just wondering, should it be tied more towards what their clinical program is? And every one of them has to have an actual plan, and that the physician and the nurse or whatever should have to fulfill whatever that requirement is. Some may require 24-hour a day, some may not.
that's the language on clinically appropriate care, in number 5. So, I think Karen Barber is up, and Claire, do you want me to go to you or to Karen?
I'm happy to like carry.
Karen, welcome.
Good morning. For the record, Karen Barber, General Counsel of DMH. I apologize I couldn't be there in person today. We would ask that the language be changed to is available to provide care. There's a couple reasons for that. One, this isn't a hospital, and this is out of line with a residential level of care. To have 24/7 care provided. The facilities are staffed 24/7 with nurses, so they would be available, but no one is getting care 24/7. So again, we would ask that it would just say be available, and that way, if they actually needed it, it would be available, but it wouldn't be a requirement that they be on site, which isn't really feasible for the facility, nor is it in line with a residential level of care. If someone actually needed that high level of care, they would, we would be looking at hospitalization.
Thank you. That does make more sense,
Yeah.
honestly. So can we just, but we can continue to use green in that area. Good thing. Is available to provide care, sir, or are, yes. Yeah. Pensioners. And Karen, anything else you'd like to? Okay, so we're good with the rest of that. That's good. It's just taking some time to get here.
So we don't have a bill.
No, we don't have the bill. I forget where it is now.
I think it's an approach.
It's an approach. Yeah. We have an approach.
So how,
We're looking at it.
okay, so that if it does come here,
We won't get it. If it comes here, it will die because it will not have made crossover.
because of jurisdiction. Okay.
Right, so it's in appropriations. Appropriations will look at any money issues there. What we have here will be a floor amendment. And I can present it on the floor. Institutions can speak to it.
Okay, thank you for that.
So all I need to know from you folks, and you can give that to me or Katie, or copy us both, about whether you'd like, does anyone know that they'd like to sign on to this at the short? Yeah,
I can support it as is.
okay. So we got big, are you ready? Yeah, so we got everybody here would like to sign on it. Okay, that's good news. And then I know that Senator Harrison wants to sign on, and her committee will be looking at it this afternoon.
Okay, so I will make those changes. I'll send a clean copy to Calista with all the names on it, and I will also send it to Senator Harrison to present. So Senate institutions can look at it this afternoon.
Thank you.
Okay,
Perfect. It's been a bit of work, but it's a really important work. This is a difficult area, so appreciate your time.
Yeah.
Okay, so now we need to move to S-190 and a proposal of amendments. Jen has. We don't have it here. I don't have it on my page. Oh, it's, yes.
If you have given.
We have
Approval to post or not. So.
Yes.
You want me to
Post
read
it.
the list
And,
and post it?
this is after we finished our work on S-190, I had thought that we were finished. with it. And then the hospitals raised an issue of, that we have looked at in here. And then we've been through some iterations outside in the Ethernet and communicated with the Premium Care Board as well as VAS on a proposal. So now there's another proposal. And I haven't heard back from, because this is all moving quickly. There's not a whole lot of time on this one. So,
Good morning, Jen Carvey from the Office of Legislative Counsel. So this is, at least right now.
and just to say, we're going to look at this proposal amendment, then I'm going to reach out both to the board and to VAS to get their perspective, and then we'll try to end this.
So I'm presuming that this, that S-190 will be amended by appropriations. They talked yesterday about taking out the language or the money for the study. And so in the sequence of events, I expect it will be this committee's report, the appropriations committee report, and then an individual amendment. So that's why it has Senator Lyons amending this committee's report as amended by the appropriations committee report. By striking out section 2, so the context of this S-190, as you may recall, is the bill on reference-based pricing and the Agreement Care Board, and a little bit now on outsourcing. Section 2 is the limit on reimbursements for qualified health plans. And so this would take out section 2 that's in the bill as you've passed it out of here, put in a new section 2, still entitled limitations on hospital reimbursements, but getting rid of that definition of Medicare adjusted base rate that the hospitals talk about not being able to calculate on a sort of standardized basis until there's more development of that from the Agreement Care Board. And so this would create a new definition of or at least for now, I called it actual hospital specific Medicare reimbursement rate. So there's no confusion about what we're talking about and what terms can be used in the future, like Medicare reimbursement rate. So that means the actual reimbursement amount that a hospital receives from Medicare for items provided and services delivered to Medicare beneficiaries. And I'm doing this in markup so you can see the changes from what you passed, but it would be clean in the Senate. So then it would still have a registered carrier, meaning an insurer offering plans on the exchange, qualified health plans, shall not reimburse or agree to reimburse a hospital more than, and then this proposal would change the 250% to 225% of the hospital's actual hospital-specific Medicare reimbursement rate for any item provided or service delivered in Vermont to an enrollee and a qualified health benefit plan. And then I put this in here just to be clear. I think somebody had questions about qualified health plans from other states, which we can't regulate, but I clarified that this is a plan issued pursuant to this Vermont subchapter on qualified health plans. And then still has that, if the carrier reimburses a hospital for something on a capitated or other non-fee-for-service basis, the carrier would ensure its reimbursement method is adjusted to account for that cap. And then changing a little bit the timing of how long this lasts, this reimbursement limit under the version you passed out would apply until the applicability date specified in the Agreement Care Board rule establishing the reference-based pricing methodology for all items provided and services delivered in Vermont hospitals, sort of coming up with what that Medicare benchmark rate is. This would instead change it to be more like the cap on outpatient prescription drugs enacted last year, and say the reimbursement limit would remain in effect unless and until the board establishes a different reference-based price pursuant to the reference pricing authority. And then it keeps the language prohibiting balance billing and requiring the board to ensure in its premium rate review that the caps in this section are appropriately reflected in the premiums for qualified health plans.
Okay.
So again, to hit the high points, this would change the Medicare reimbursement rate that the hospitals and insurers would be using in applying the cap. and changing the amount of the cap from 250% to 225%. Based on that. Based on that different calculations.
So questions of clarification? Go ahead.
How did we get from 250 down to 225?
Okay, well, good question. We'll get there.
That's my question.
Okay, that was my question. Okay,
Yeah, I have a real thing. You want to hear from?
okay, so before you have a problem, let's listen to, I have a problem. Also, I mean, the hospitals came in and wanted to change everything that we had done with regard to QHP. And we were not completely, I understand. We wanted a different Medicare base rate for hospitals. I'm going to go to the Green Mountain Care Board and Emily Brown. And because one of the recommendations that the board made when we suggested a change was to go to a lower rate. And so, Emily, do you mind talking, please, explaining from your perspective what this proposed amendment will do to the work that we've
Sure. Thank you. Emily Brown, Executive Director at the Green Mountain Care Board. So the definition that was originally in there was the Medicare base rate. And so this was a rate that would have been uniform throughout the system. And then is also a rate that's usually lower than what the hospitals are actually reimbursed, which if you look at the language in this amendment, it refers to, sorry, I'm just going to pull up the language. Jen, if you could help me, what the hospitals actually reimburse.
The actual hospital specific care reimbursement rate.
So that would be a higher number. And originally our estimates on the cost savings were based on the base rate in the 250%. So because this definition would then allow for a higher Medicare reimbursement rate, we felt it appropriate to lower than the percentage, because then you're accounting, and we haven't had time. This has been moving quickly. We haven't had time to do and generate an estimate of what the lower amount would be that would kind of match where we had been. But it would definitely be lower than the 250%. And then just going back, the reason why we had originally suggested the Medicare adjusted base rate was because that's what we are planning to implement when we move to reference-based pricing. So if we go with this actual hospital-specific Medicare reimbursement rate, it would be a deviation from what the direction of the Green Mountain Care Board is now for reference-based pricing. And again, I hear the hospital's concern about being able to calculate it. I think I've talked to my policy director, and I think there is an option here where the board would be able to publish the Medicare adjusted base rate. Again, going back to that prior language, because I think there was concern about the hospitals being able to calculate that and relying on the insurers. So, we're willing to try to work with VAS to figure out how we can make sure that there's a uniform understanding of what the Medicare adjusted base rate is. But, that's kind of, I think, where we are right now. And again, trying to respond in real time to these changes. So.
Okay, so what I'm hearing you say is that you are willing to work with VAS to change the language so that there's less responsibility given to the hospitals to determine that Medicare base rate.
Correct. Yeah.
And so we can hear from VAS at this point, but that is a preferable solution to the problem from my perspective than trying to go through and reevaluate the numbers and then look at another step in getting to our reference-based pricing. So I'll leave it there, but Do you want to comment, Devin?
Sure, thank you. Devin Green, Vermont Association of Hospitals and Health Systems, and appreciate this committee trying to address the concerns of the hospitals on the definition of Medicare in this space. My concern with the 250 going to 225% is that the Green Mountain Care Board originally testified that this would impact hospitals by $50 million. When we did this calculation on the tool that they've put out around reference-based pricing that has that base rate, their definition, that comes to $72.7 million, which is not the $50 million that was originally proposed. I have asked the Green Mountain Care Board about this calculation. They have not gotten back to me. And so we are trying to figure out, I assumed the 250 was 250 of our definition, 250% of our definition, which is how they got to the 50 million, as opposed to this 72 million, which changes things significantly for us.
Okay, so here we are, we're at a place where we need to finish this thing off, literally, really. So what I'm going to suggest is that the board and VAS get together, and I'm leaning very much toward the language of having the board support the hospitals in their work to look at what that Medicare reimbursement or adjusted base rate is, what the reimbursement rate is for hospitals. There is language in the bill that offers forgiveness to hospitals. One of the reason we started all of this stuff in the first place was to make sure that hospitals remain sustainable. And so I'm not thinking that the board is going to allow for some catastrophic financial result for hospitals. And this is a tough place for us all right now, because we know things are getting harder to do. And so all of which to say, I'm gonna just say we have a couple of proposals before us. The board would have said 200%. I said that seems very low. Let's put 225 in. I asked Jan to do that. But the board may have some other recommendations. They've got the data. And so I'm going to suggest that we leave this for now and allow for the board and the hospitals to come together. This bill is in appropriations. It's being sent out tomorrow to be on today, to be on notice tomorrow. And I need to have some resolution in this committee before then, because the appropriations isn't looking at this. This is not their jurisdiction. So I'm just saying that's my thinking. And I think I just have to say, committee, I think this is the best we can do at this point. Hospitals are going to be petrified. I get it. It's not easy to look at savings of this type, but it's something that's important for folks who are seeing escalating premiums. And we know we've been through all of that. So we get it. We all get it. So anyway. So can the board and VAS have a conversation, please? Emily?
Yes, we'd be happy to do that.
And Devin?
Yes.
And Laura? Two against one. All right. We'll be good. And I know there's a concern about having insurers dictating pricing. That can't happen. This has to be something that is a process between board and regulated entities. DFR will be looking at insurance, but I know it's a three-way problem. But the regulatory process between board and hospital is going to be critical. I wanted to put that out there because I know that's a problem.
So this Green Mountain Care Board and the hospital's going to work on the definition of Medicare.
The Green Mountain
And
Care
whether-
Board and the hospitals are going to work out a solution to the hospital's concern that they would get more money back with the hospital definition than they would get back with what's currently in the bill. The reality is that we're moving toward what is in the bill, which is a Medicare adjusted base rate. And so we're trying to do it in with a process that doesn't, cause a misalignment or hurt problems for hospitals. It's an itchy place to be. So what's in the bill allows for the board to offer some help to hospitals when it looks like they're.
So, just so you know, Madam Chair, I will be consulting with my hospitals at home, of course, and also.
They don't want to do this.
Well, I understand that. And I also wanted, I don't know where the 225 came from. I don't think anyone's answered that question.
That's the board.
And that was a big bone of contention in festival here, as I recall. So
250.
Yeah.
250 is good if you have the definition that we have.
Correct.
If you put 250 on top of the increased amount hospitals are getting, that doesn't lower the amount going in. And so, and I'm gonna let you guys work this out outside because I can see head shaking in both directions. Emily, you want to comment?
Yeah, I mean, I again, my point was when when we were communicating on this yesterday and this morning, was that if you're going to change the definition to allow greater reimbursement, then you would have to go lower than 250. I didn't suggest the 225. I think that was the middle ground between the 200 and the 250 and what was put in there. But again, we haven't done analysis on anything aside from the 250, which was the basis of our original proposal. So I think changing the definition creates a lot of variability. It creates variability between hospitals because each hospital is paid differently by Medicare. So with the original definition, it creates uniformity. So
We call it alignment.
Alignment. Okay, sorry, alignment. So again, I think the board would prefer the original definition, and if with help facilitating the hospitals on the calculation.
So
yeah.
So here's my ask of the board and the hospitals. The hospitals are afraid that they're going to lose more than the $50 million predicted. So the prediction is $50 million. They don't want to lose the other 20 million. We get that. So there's language in here that would kind of ameliorate that concern. The board will help to ensure hospitals don't lose too much. So maybe there's an improvement on that language in some way that offers reassurance.
Yeah.
And going back to our,
I'm sorry.
so I'm just going to say this, I have to put this in your hands. Otherwise, we're going to wordsmith it and it won't be lovely.
And I don't want to vote for a bill that I have and then vote against.
No, no. Look, there's a legitimate concern from the hospitals. They're stepping into new waters. They want to be able to swim. So we need to put the life jacket in here. So can you please do that for us and communicate with Jen as you come to some understanding? And we have to leave it at that. Thank you.
Thank you.
Good luck. And now we look for this because we'll be back on it tomorrow morning, right away.
Okay, thank you.
And we're trying to understand, we do understand, we don't want to leave people high and dry. At the same time, the goal is some alignment of payment reform that has been so critical right from the beginning. Okay, that was fun. Thank you both. I mean, look at Laura and Devin and Emily for both organizations. Thank you for being here. Okay. So now we need to inhale a little, take a break. And we'll move on to cannabis.
Speaking of India.
All right.
Are we?
Yeah, I think-
Stand
I
up,
think it's-
2 minutes.
Stand up, don't leave. No, we can't because we only have another.
But I mean, I actually have.
I'm close.
I promise.
We're good. I think we're good. My message was to you what I was saying earlier. Okay. I'm by the chest.
See you again. Nice to see you.
If there's
How you
language we
welcome
can
me.
put in. If
How are you?
language we can put in.
Good. You?
If we
Good.
can insert some language in that
I'm learning more about cancer. I know that.
eases the pain.
When you come down, are you ever inside? No, I got quite a few. Your farm. I got, Cam Deborah.
Yeah, we talked about, yeah.
Go for it.
You give me one.